Hello, friends. Today we are back with another segment of conceptual surgery. And today we'll be talking about preoperative management of patients with adrenal tumors. Now, the outline of this session would be first, we'll talk about why this is important to understand special preparation of adrenal patients, because these are these pre-op management or pre-op preparations are more important for certain diseases and certain organs. So why adrenal is one such organ? We'll talk about that. We'll talk how to clinically evaluate patients of adrenal tumor, how to medically optimize, what are the various anesthesia considerations, and what all we need to do to prepare a patient psychologically, and then maybe some bits about logistic plannings of such cases. So why do we need to talk about adrenal tumor is important. We don't talk about every other organ in the same way as we talk about adrenal. Now, this is a typical picture of a patient with adrenal tumor, and patient will have hyperhidrosis, patient will have signs of anxiety, patient will have hypertension and all that. But what happens mostly, the surgeon also is in a similar condition, because this organ is very critical, and this organ, the surgery of this organ is very critical, and it leads to a lot of physiological changes. So the surgeon, the anesthetist, and the patient all looks the same before the surgery. So adrenal surgery is very complex and critical procedure. Yes, it is an essential endocrine organ. And a lot of substances which adrenal secretes has a role in regulating metabolism, immune system, blood pressure, and other very essential functions. So any manipulation of that will lead to a lot of disturbance in these conditions. So that's why the surgery becomes a little more important and complex. It secretes hormones like cortisol, aldosterone, adrenaline, and noradrenaline, which are very important for the body, and slight fluctuation of these levels can lead to a lot of physiological changes in body. And outcome generally depends on surgical technique, but also with how well we have prepared the patient. You will very often hear in adrenal patient that patient did not do well or did very well because the pre-op preparation was very good, and the whole intraoperative and post-op period were very smooth. So I think one such procedure where surgical technique is important, yes, but also it is very important how we manage pre-op, post-op, and intra-op. So what are various management? If we talk about adrenal mass overall, it can be functional tumors, or it can where we treat according to what hormones or substance it is secreting. So like mineralocorticoids will be treated separately, pheochromocytomas separately, cortisol secreting tumors will be treated differently. And there can be non-functional tumors, which generally are categorized according to size. If they are less than 4 centimeters size, then we generally follow up. Non-functional tumors less than 4 centimeters, we can just follow up by imaging over 6 months, 12 months, 24 months, and so on. And if we see any increase in size, then we can choose to operate on these. If it is more than 4 centimeters, typically we go for surgical excision. So that is a very nutshell. In a very ambiguous way, we follow this flowchart for adrenal masses. Now, if we talk about adrenal surgery, what are various indications? The most commonly are adrenal tumors, where we have to go in for adrenal surgeries, and it can be adenomas, which are benign but substance secreting hormones, and based on what substance they secrete, it can be hyperaldosteronism, where it secretes aldosterone. It can be Cushing's, where it secretes steroids, or it can be pheochromocytomas, where it secretes noradrenaline and epinephrine. And it can also be malignancies. Generally, malignant tumors are aggressive, and they spread, and then they increase in size rapidly. Sometimes, though rarely, they also can be secreting tumors. So you can have a malignant pheochromocytoma, which will be malignant, but also secrete adrenaline and epinephrine. So though it is seen in 10%, but it is seen. or it can also be in case of adrenal insufficiencies on the other end of the spectrum where adrenals is not functioning. So then also we can end up removing because of the malignant condition, the tumorous conditions. It can be adrenal insufficiency, which is called Addison's disease. It can be congenital adrenal hyperplasia. Then in children also can be indication of removal of adrenals. So before going for surgery, as for any other organ, more important for endocrine organs, because all the endocrine organs, be it thyroid, be it parathyroid, be it adrenals, you have to understand the pathology. Then only you'll be able to do a very good job with the overall management. Now, surgery, we all know, and we are all understand this, that surgical procedure is just a part of the whole treatment. Okay, but it is more so important in when it comes to endocrine organs. So how we clinically evaluate these patients? Obviously, a very detailed history and physical examination is required, which entails medical history, which entails family history for other hereditary conditions like multiple endocrine neoplasias, a thorough physical examination to look for the changes, any physiological changes, which can be because of these endocrine imbalances, or any other sign of endocrine imbalances in other glands and other organs. Mostly endocrine malignancies, they tend to affect many conditions. For example, let's say a patient has features of aldosterone secretion. Now, it can be because of a primary disease, but it can also be because of, let's say, pituitary tumor which secretes ACTH. Now, whenever a patient has ACTH secreting tumor, it can have effect on other glands also, like thyroid, like melanin secreting glands. So you will see those signs in the patient. So look for these signs and do a thorough physical examination in these conditions. Pheochromocytomas are associated with some thyroid malignancies in men. So look for those signs as well. Do not just go, that patient has come with a report that this is an adrenal tumor, and we start just operating on that. That is where I say you have to understand what is going on before putting the knife on the patient. The second main important part in this adrenal tumors is cardiovascular assessment, especially if the patient is showing sign of adrenal medullary tumors or pheochromocytomas. So do manage the hypertension, do evaluate hypertension. Do also look for cardiac abnormalities by doing an ECG and echocardiogram. These patients tend to have cardiovascular derangements, so do look for that. Also, we need to do an anesthetic risk stratification based on various factors. So do consult an anesthetist at this point, and where we can label the patient initially also of what anesthesia risk a patient has. There are certain imaging which we need to do. Now, biochemically, we'll be able to diagnose whether the patient has a functional tumor or not. But localizing is also important. Sometimes it can be a single focus. Sometimes it can be a bilateral disease. Sometimes it can be a disseminated disease where patient will have metastatic functional tumor sites. So identification that where all is a secreting tumor is important. So the various things which can help is CT MRI or a MIBG scan, which is a more reliable scan, or maybe PET scan also. The current PET scans can pick with specific thing, but I think MIBG scan is the mainstay which we do.